And we're back with Luke Heath for the first time. Luke's the fourth individual from Aspetar. We've had Enda King, Rula Katsufaki, Catherine Fahy. Now we have Luke Heath. So just the powerhouse team that you all have is amazing. Luke, for people that aren't familiar with you, can you tell us about yourself?
Yeah. Thanks, Chris. And mate, firstly, just thanks a lot for having me on. And I'm genuinely humbled to be a part of this podcast. I'm a listener, and you've had some incredible guests. You've just named a few of them, including Ender as well. And you've been putting out some really good stuff. So I appreciate the opportunity, mate. So yeah, just a bit about myself. I'm a sports physio by trade. I'm from Australia, and I've spent roughly a decade in Australia working in full-time professional sport across various codes. And that included rugby union, a stint in the Australian Football League, the AFL, and also some time in football or soccer. Um, and after about 10 years in full-time pro sport, I was ready for something a bit different. And what I really enjoyed about sports physio is the Monday to Friday. Which is the rehab process and helping athletes recover and get back to performance. And that's what gives me my satisfaction and a bit of a buzz. So an opportunity came up at Aspetar, and I've been here now for close to 2 years. And my role specifically is I'm the senior physiotherapist, and I work specifically in the knee group. And I'm basically the captain of the football team. I have a very, very experienced, good team of 8 physiotherapists, and we work very closely with the strength and conditioning staff. And our bread and butter is ACLs, but we also manage a wide range of knee injuries. And what's unique about our setup here at Aspetar is that we all have our specialization groups. So in the knee group, if all you're seeing is knees, and we have up to, say, 100 athletes on our books at any given time, and 20 to 25 or so are international level players, you naturally get very dialed in on the nuances of knee rehab. And it's a privilege to work in that kind of environment. And I guess the other thing that attracted me to Aspetar, and the thing that's really exciting at the moment, is that there has been a big recruitment drive over the last few years, and I'm fortunate to be a part of that and surrounded by some incredibly experienced physios who have been at Aspetar for a long time, but also some new staff bringing some energy and some new thoughts. And the water cooler conversations and the daily learnings in the environment have been invaluable, and they're great. It's a great place to be a part of.
Yeah, I originally found out about you because the Aspetar PDF on knee examination came out a few months ago. I reached out to Rula and asked who created this document. Would love to have a conversation around kind of a thorough knee exam, and she referred me to you. And then we ended up talking in more detail about maybe elaborating the conversation to not just an intro knee exam, but what does an examination look like throughout a variety of timelines in someone's rehab. So what we're going to do today is discuss this kind of initial injury examination.
Yep.
What would this look like? And then assuming someone has an ACL reconstruction, as a clinician, what are these recommendation and key things to clue in on throughout different parts of the phases of rehab? What exam pieces are beneficial? What is it telling us? How are we adjusting it? So, Luke, I'll have you start with what would an initial exam of the knee look like for someone just had an acute injury?
Yeah. So yeah, the document, it would be a really good resource for people looking at how we assess things here at Aspetar. And it was put together by the knee group. And it, it's available on our website, which is a really good resource for medical professionals. But specifically, to start with the initial assessment, so someone's come in and they've hurt their knee. I think getting getting your initial assessment is absolutely vital. You have to get it right. And the most important component before you get your hands on the athlete is to dial in on your subjective examination, and and gather information through questioning, because that then guides what you do in your objective examination. So something I tell a lot of new graduates and I tell a lot of younger physiotherapists is just take your time with your subjective examination and make sure you're very thorough. So first and foremost, you want to get a clear picture and an understanding of what the mechanism of injury was, and this also plays enormous insight into the structures potentially involved. So for knees, in particular ACL injuries, there are three primary mechanisms that we need to consider. So the first mechanism, which is very common, is the non-contact mechanism, where an athlete changes direction or they land from a jump and an injury occurs, and that's without any external force or contact. Another common mechanism is indirect contact, and that's contact somewhere other than the knee. So, for example, an athlete's airborne or changing direction and they get shoulder barged, and then that force indirectly causes them to twist their knee up. And there's also direct contact, which is pretty self-explanatory, and that's a direct blow to the knee or the lower limb itself. I find getting video footage for understanding and having a look at the mechanism of injury really, really important. But if the video footage isn't available, I think getting an understanding and acting out with the athlete, okay, where was your knee at the time of injury? Was it that knee valgus position, or was it a hyperextension injury? And that helps give you an idea of what structures you need to specifically look at and might be injured. So, for example, if someone's done a big contact injury and it's a hyperextension varus injury, you need to have a look at a lot of structures: ACL, PCL, their posterolateral corner, their LCL. You have to have a look at their common peroneal nerve. You have to have a look if there's a tibial plateau fracture and bone injury. So that's just one example of a high force incident, but you need to clear a lot of structures off, and you get that through your questioning. Once you've sort of got a good understanding of how the incident has occurred and the position of the knee was in, you also have to ask the location of the pain to the athlete and what brings on their pain. And something that should raise a lot of suspicion about an ACL injury is that posterolateral knee pain. So this often results from bone bruising or impaction at the time of injury, and that happens when the tibia subluxes and the lateral femoral condyle and the lateral tibial plateau collide and bang into each other. And this pain pattern can be very telling. So imagine you're running on the pitch and an athlete says they're twisted up their knee, and they're saying they're pointing to lateral knee soreness. So you should have a high suspicion of an ACL injury until proven otherwise, and you need to examine that. Another thing which you also need to question is the amount of swelling and how quick the swelling came up. So if an athlete experiences swelling within the first 20 to 30 minutes, that's a rapid joint effusion, and that suggests intra-articular bleeding, and that's often seen with ACL injury. Other critical subjective questions that I often ask is, did they hear any noises? Did they feel a pop or a crack? And does their knee feel unstable? When they're walking, does their knee feel like it's giving out from underneath them? And are they experiencing any catching or locking sensations in their knee, which may also suggest any meniscal or loose bodies getting caught in their knee? And then another little telltale sign about an ACL injury is that the pain is pretty intense initially, and then it sort of dampens down a little bit. So that can also be another telltale sign that they've injured their ACL. Then I also go into sort of some special questions which raise sort of some red flags, such as some neurological questions. So is the athlete feeling any abnormal numbness or pins and needles in their lateral lower leg? Or do they have foot drop? And that may be with a more significant knee injury where the peroneal nerve is injured. And then also something which is really, really important to ask your athletes is their past history. Have they injured their knee before? Have they had an ACL reconstruction before? Because how their ACL examines will be very different if it's been reconstructed, will examine very, very differently. And they may have more play in their Lockman's test and may feel a little bit looser. So that's also really important, is to get an understanding as to what their past history is. So that's the important part, the subjective examination. And then I dive into my objective examination, and whether it's on the field or in the clinic, I try keep it the same every time. And firstly, you're looking and observing how the athlete's walking, how whether they're limping, whether they're able to fully weight bear. If you're on the field, obviously they're on the ground most of the time. You're having a look at their limb position and their willingness to move as well. And then jumping into, do they have a joint effusion? Do they have swelling? So that's done with our sweep test or a patella tap test. I then examine what their range of motion's like, looking at active and passive knee extension and knee flexion, and you're looking for any pain, any blocking, any guarding. And then you're diving into your special tests. Specifically for our ACL, we're looking at the Lockman's test, where we're looking for ACL integrity. So what you're looking for the amount of play that they have when you're pulling their tibia anteriorly. So how much play they have, and compared to the other side. And then also you're feeling what their endpoint feels like. Is it a firm, brisk endpoint, or is it soft or absent? And that's obviously a significant finding. I then jump into their anterior draw to also assess the integrity of the ACL, and this is a bit harder to interpret than the Lockman's test, and you have to ensure that the hamstrings aren't guarding. And then whilst I'm in that position, you can also assess the PCL as well with a posterior draw. The third test for ACL integrity, I look at the pivot shift, and I assess the anterior translation and rotary instability. And then I look at my collateral ligaments, looking at the valgus stress test and the varus stress test, both at 0 and 30 degrees. And it's important to look at both. At 0, you're looking more at capsular as well as ligament integrity, but then at 30 degrees, you're looking at more that ligamentous integrity. And again, you're looking for laxity and pain, and feeling for endpoints as well. I then jump into the McMurray's test to investigate meniscal pathology, and then the last special test I usually go into is the patella apprehension test if there's suspicion of MPFL injury or lateral patellar instability. So they're mostly the special tests I go into. Obviously, if there's other knee pathology, you can do a bit of a deeper dive. But then I generally jump into palpation. And then with palpation, I always routinely check what the medial natural joint line are like. And I think a really important thing, which I was taught early in my career, is when you're palpating the joint lines, don't just dive straight around to the, say, medial part of the knee and go, okay, yeah, I think that's where the joint line is. If you start around more anteriorly, you can feel the femoral and the tibial condyles, and then you can sort of nestle your finger into that joint line as a point of reference, and then start to palpate medially or laterally on that joint line, and make sure you go right around posteriorly as far as you can go. And then you sort of dive into other parts of the knee that you need to clear off based off your subjective and other objective part of your examination, such as the MCL, LCL, hamstring tendons, fibula head, patella, any bony structures that you need to palpate to help with your diagnosis. And then you want to have a look at what the athlete's functions like. Importantly, looking at what their quad functions like, what's their quad contractions like, because this is quite important to clear off and rehabilitate in their pre-op if they have a confirmed ACL injury, and then having a look at their functional assessment to get an idea of how irritable the athlete is and determine what their functional status is. So you're looking at their gait, looking at their squatting pattern, calf raising, and that's pretty much a lot of their assessment. So just my final thoughts on the examination. All of it is underpinned by your clinical reasoning, and it just starts with the subjective examination and what the athlete's story is to you, and obviously it's then finished off with your clinical physical examination. So, and what you felt, and the aim is to build a clear diagnosis and then identify any red flags, fractures, neovascular compromise, or DVT. And then you need to give the athlete an immediate plan, whether it's referring on for imaging, whether it's referring on to an orthopedic or a sports physician, whether they need bracing, crutches, and then also beginning their rehabilitation. And an accurate early diagnosis can significantly influence the rehab trajectory. So it's important that we get things right.
That was great. So that was a very thorough initial injury examination. Now let's jump forward. Let's say it's a confirmed ACL. There was the decision to undergo surgery and ACL reconstruction. Let's start with that initial post-operative ACL exam. Can you touch on kind of when that typically occurs, the few days out of the surgery, and then what should that look like?
Yep, sure thing. So it depends on what type of surgery that they've had and what other structures have been operated on in the surgery. But let's just say it's a ACL reconstruction with no other meniscal or no other ligaments done. So they're usually seen in the first 3 to 5 days after their surgery. And the initial goals, again, starting with your subjective history, you need to clear off any red flags, and specifically, you want to ask the athlete how they're going, what their pain levels are like, whether there's the medication that they're on is effective, and then whether they need anything more, how they're going with their activities of daily living, how they're going with their mobility, their use of crutches and sleeping. And I specifically ask them about, do they have any calf pain, to rule out a DVT, which is really, really important. Asking them about their general health, how do they feel unwell? Do they have a fever? Are they febrile? And that can sometimes be signs of infection, which is very, very unlikely. And I guess if they do have the DVT, if they have abnormal amounts of pain, and if they aren't feeling well, they're immediate signs that you need to escalate things and call the surgeon up right away. And the beauty of things at Aspetar is if you call a surgeon up, if they're not in theatre, they can usually get around and come see the athlete straight away, which is great. So you then sort of go into other questioning with the athlete. So what's their comfort like at home and how they're resting. And then I think with the resting position, what you really want to dive into, are they resting with their knee out straight, or are they resting with some pillows propped up underneath the back of their knee, which is a big no-no. Because one of the key things that we want to do in the first immediate part of their rehab is we want their knee straight. And the worst thing is that we see an athlete after 2 to 3 weeks and they've been resting with their knee with the pillow underneath the back of their knee, and they come in with a fixed flexion deformity, and it's an absolute disaster trying to get their knee straight. So I think part of that is the education piece, which I'll dive into very shortly, which is a part of the first initial consult. So, And then you sort of ask them how they're going with some exercises that they may have been given from the team up on the wards, and some physios straight after, and if they have any problems and what their daily routines like, how often they're doing the exercises, are they resting, are they icing, what their resting position's like, are they getting elevated, are they going out and walking around at malls, which is a big no-no initially, and people there, you wonder why their knees all swollen and irritable. So I think diving into what the athlete is doing early on is really, really important. Then diving into the physical examination, once you've asked all those questions and you're satisfied, they always present with bandages, but having a look at their leg and what their swelling is like, and if anything abnormal is going on. You have a look at their active and passive knee extension, making sure that they're working towards that full active knee extension early. You have a look at their quad contraction, whether they can activate their quads, and that's obviously a huge marker of success. And then you have a look at how they're bending their knee as well. I often will palpate their calf to obviously check off that DVT, and obviously escalate that with the surgeon if there's any issues there. And then also, really importantly, having a look at how the athlete moves when they're on their crutches early on, making sure that they're safe, making sure that crutches are at the right height. That's done really well at Aspetar, but in clinic, you often see people come in other places that I worked at, they've had surgery wherever, and you need to make sure that everything is sound and they've been taught to use the crutches correctly. And then on to, after you're satisfied with your physical exam, the education piece I think is really, really important in your first consultation. And in your first few consultations, you want to tell the athlete what the plan is and what they need to do in the first 6 weeks and what targets they need to hit. And I drive home that we want to get their swelling down, we want to get their knee straight, and we want to get a nice, good, solid quad contraction early on. So they're the points that I drive home really, really hard with your athletes, because if they don't do that, and they have a bent knee, is that they can start to develop a cyclops, which is a bit of scar tissue anterior to their ACL, which sometimes there's a window that you need to get that knee straight, and if the door closes, they then are stuck with a bit of a fixed flexion deformity, and the only way to fix that is through surgical debridement. So you want to avoid that, and that will obviously hamper their progress. So I sort of drive home those points. And then the other goals are knee bending, but that usually comes back pretty easily. And then some introductory lower limb strength work and motor control work, which is in the background of those main points. And then one big point which I iterate is that discomfort and a little bit of pain is absolutely normal. And it's okay to work through a 1 to 2 out of 10 pain, but be guided by how the knee feels. The knee knows best. So if your knee swells up after some treatment, you've done too much, or whatever you've done, you need to look at what you've done and reflect on, maybe I shouldn't have gone for that walk at the mall or whatever. But listen to your knee, let pain and swelling guide the progress of your knee. And I sort of reiterate that in the first initial consult.
Now they're done with that initial examination. They're coming in subsequent days and weeks, but they're still in this early stage. What does the day-to-day exam look like for these individuals?
Yeah, so our daily assessment plays a critical role in monitoring how our athletes progressing and guiding through their rehab. And the goal is to determine how the athlete has responded to the previous day's treatment and whether anything has changed, and whether through the rehab, that's through rehab activities or something that may have occurred at home, like they're doing way too much rehab at home. So there's some really simple key components that we focus on assessing every day. Number one, we need to check in with what the athlete's pain levels are like. So how is their pain more, same, better, or worse than yesterday? And I think that's a really important question to ask. Um, and an increase in pain may indicate overloading or a reaction to specific treatment that was done the day before. So it's important to dive into that. And then another key component to measure and look at every day is swelling. So we assess swelling using the sweep test, and then you can be really specific as well. And with a tape measure, you can measure what their swelling is like with three key landmarks being the infrapatellar, the mid-patellar, and the suprapatellar. And you track that every day as well. Again, if swelling is increased, you follow up with some questions. Okay, is it from physio yesterday? Is it from what was done at home as well? So you that can sort of change what you do for that day and mark whether your athlete is trending or regressing or plateauing. You then look at their range of motion, so daily checks there of their knee extension and the difference between their sides of their knee extension and also their knee flexion range of motion. And then I also look at what their quality of their quad contraction is like as well. And as I discussed before, a strong quad contraction is a key marker of the recovery in the early post-op phase of their knee. So as I said, these daily checks they help identify trends, positive, negative ones, allows us to tailor our rehab for the day, and consistency in these knee assessments ensures we pick up on early warning signs and keep the athlete progressing safely.
With something like the sweep test, it's very objective. There's grades to it. It's
Yep.
easy to objectively determine if there's change. For something
Yep.
like the quad contraction, it seems maybe a little bit more subjective. Do you have a descriptor or an idea of how does a clinician determine is this a good quad contraction?
Yeah. So what we've done with the team here, we've discussed this at length, and we've come up with a really objective way of measuring a distal quad contraction. The traditional way is just to do an active straight leg raise, and you can measure the knee angle at the joint when they're doing that. And I find that there's a lot of variability between clinicians in doing that. So what we came up with was a very simple way in doing it. So grade 0 is that they physically can't lift their leg off the bed when in doing an active straight leg raise. A grade 1 is that they can do an active straight leg raise, but there's a quad lag. A grade 2 is that they can do an active straight leg raise and their knee is at 0 degrees. And then grade 3 is that they have full symmetry um, between their legs. So a good way to do that is if the athlete is supine on the bed, they do that distal quad contraction and they lift their heel up and at the same time driving the back of their knee into the bed. And what you can do, you can just slip your fingers underneath their lower leg and just go, okay, this guy on their good side, they're coming up towards their sort of their MTJ of their calf or the gastroc heads, and on the other side they can't even get their heel up. So they're not symmetrical yet. So that's a good little way that you can assess it, and that's the grading system that we have at Aspetar, which is also available in that PDF.
There's probably variation with this answer and what you see, but for maybe younger clinicians that are maybe hesitant or uncertain as to is this progressing at the rate at which is appropriate or that it should. For something like swelling, they're tracking via the sweep test. How long does it typically take for you all at Aspetar to see significant changes, let's say from post-op, week 1, they're at a 3+ to come down to a 1+ or trace? And like I said, there's probably quite a bit of variation, but is there a general timeline of when you would expect? And then same thing for extension range of motion, comparing to the non-surgical limb. How long will you would expect for someone to get pretty close to the other limb's extension range?
Yeah, good question. I find that there's a lot of variability in swelling between athletes, and some people can go down to a grade 1 at week 5 and you're absolutely flying, and another guy, what we we like them to come down before 8, 9, 10 weeks, and they're pretty good at 12 weeks. But some people can still have that lingering grade 1 for a longer period of time, and after 12 weeks, up until sort of 4 months, they can still have that. But what you want to see at that stage, if they have sort of that trace to grade 1, is that with loading and with rehab, it's not increasing and it's sort of just flatlining. Um, you don't want any more than that grade 1 really before if they're going on to jumping and running. But as I said, some people with other knee pathology like chondral issues, they can sort of carry a little bit of swelling. And the other thing is that some people are just swellers and they carry swelling for a little bit longer, and you may need to discuss some medical interventions with the surgeon at different time points to give things a little bit of a hurry along. So, because it can hamper you regaining terminal knee extension and a distal quads contraction. And as I said before, we like that distal quad contraction and that them to regain full terminal knee extension within 6 weeks. So if you got it within 3-4 weeks, you're doing a really, really good job. But some people can linger and take a little bit longer, and up to 6 weeks. And you just don't want that door to close and them to get that scar tissue anterior to their ACL, which is that cyclops lesion, which is problematic.
Going to, you differentiated to a daily examination versus a weekly examination.
Yeah.
Can you describe what that looks like?
Yeah, so the weekly assessment is a good little checkpoint in your ACL rehab. And while progress may be incremental, this assessment allows us to identify any emerging trends, detect subtle regressions, and also fine-tune our interventions. So we typically conduct this exam at the start of the week, and the athlete's fresh after 1 day off or 2 days off from aspetar, depending where they're at in their rehab. And the initial part of the exam focuses on the subjective feedback and those daily standard checks, which I mentioned before. You're asking their pain levels, you have a look at their swelling, and their response to the previous treatment, and then you have a look at their range of motion and their quads contraction. But then diving deeper into that, we then want to have a look and build beyond those daily checks and have a look at what their motor control and functional testing looks like to evaluate how an athlete's truly moving. And we use a systematic approach in how we do that. And when we're looking at someone doing a functional movement, we look at them from the toes and work our way up through the kinetic chain. And we have a look at, are there any compensation patterns, and are they doing some specific actions, which I'll dive into now? Are they doing that well, or do we then need to do a further deeper dive on that weekly check? So the key functional assessment that we look at, it starts with a squat, being double leg, then progressing to a single leg, and then also having a look at a double leg calf raise, progressing to a single leg calf raise, looking at their toe off mechanics. So when we're looking at someone's squat, initially we look at them from the front, and what we look at, starting with the foot, we look at their foot positioning, and when they're squatting, is their foot in external rotation? Is their midfoot collapsing? And we then want to get a gauge as to why is that happening, okay? And then we then have a look at the knee. How are they squatting? What's their knee position like? Are they diving into knee valgus? And then we have a look further up the chain. Are they sort of swaying to one side and not squatting and taking load through that their affected side? And we also have a look at what's happening with their trunk. And then side on in the sagittal plane, you can have a look. Are they underloading the knee and hinging through the hip when they're squatting? And what's also happening? Are they able to reach full terminal knee extension as they finish off their squat? when we're looking at their calf raise and toe off mechanics, we want to have a look at, are they able to get right up onto their toes, or are they lacking some calf strength? And why are they lacking? Is it just true calf strength, or are there some deficits through their first MTP? They can't get up through their first MTP because of stiffness through the joint or weakness, or do they have some poor midfoot stability, or are they weak through their perineals or tib post, which may affect them in other actions? So these are their squat mechanics, and their toe off or their calf raise mechanics are really, really important to look at, because they then set up what they're like in jumping actions, what they're like in running, what they're like in changing direction. So we have a look at these key foundational movement tasks, and then as their rehab's progressing, once they're clean, we then look at, okay, harder actions. So we're moving further up the totem pole and we then look at them doing a single leg pogo. We then look at them doing a counter movement jump, a single leg counter movement jump, running, change of direction. But what these functional actions are, they don't give you all the answers. Okay. So we have a look at these key functional movement tasks, whatever they are. It usually starts with their squat, their calf raise, and then moving to those harder actions. But then that doesn't give you all the answers as to why there might be some deficits. So we then need to go into a more detailed regional assessment, and that might be of their knee, that also might be of their hip, and also their foot and their ankle. So specifically starting with the knee, as I said, we're looking at their range of motion. So for example, are they not reaching full terminal knee extension on their squat because they got a deficit in knee extension? So that's just one thing. But then also in their knee, we look at their tibial internal rotation, and basically what that is we got their knee at 90 degrees, their hip at 90 degrees, and their foot in neutral, and we're rotating their tibia internally, and we're comparing that to their other side. And if they have a lot of stiffness there, what we often see is when they're doing a squat, their foot spins out into external rotation, and that's not ideal. Their knee then goes into a bit of valgus, and that puts the knee in not a very good position, but they can also get grumbly with some anterior knee pain. So we want to make sure that we address that tibial internal rotation through some joint mobilizations or some specific rehab. Then diving into the hip, we have a look at what their mobility is like through their hip. So internal, external rotation of their hip joint. We want to have a look at what their hip flexor tightness is like through a Thomas test. And then also some manual muscle tests through their lateral hip. Have a look at what their strength's like through their hip. Also have a look at what their deep rotators are like through their hip as well. And then you can dive into their foot and ankle. And again, I gave a little bit of a mention to it before. If they're quite stiff through their first MTP joint, that'll affect them getting right up in that toe off position. So we need to address that. And then they also might have some weakness through some specific muscles, through their big toe flexors or through their tib post. They might have some midfoot collapse, which we need to address, or some perineal strength deficits, which we look at with a manual muscle test, where they may affect their toe off position as well, where their foot's sort of spilling out into inversion. So these are all detailed assessments that we do on a weekly basis, and it's really, really important to look at them, whether it's control, whether it's mobility, whether it's strength, and we address these deficits directly in their rehab plan. And we also monitor it week to week and trying to close the gap and improve them. And this allows us to target interventions precisely and progress their exercises safely. Or if they're not being restored, we need to ask ourselves, why is their lateral hip strength not improving? What is it? Is it the rehab that I'm giving them? Are they feeling the exercise in the right spot? and then it keeps us accountable. So I guess the weekly, just to wrap up the weekly assessment, we have our daily measures, which we monitor daily, um, and we see trends week to week there. But also we look at those biomechanical and motor control deficits, and it ensures that we're programming our programming is individualized, it's progressive, and it's purposeful for our athletes. And in ACL rehab, it's a long rehab, and the changes aren't dramatic week to week. But as long as we're making small progress week to week and making sure that they're not flatlining or regressing, that's why that weekly assessment is really, really important.
All right, zooming out even more, you called it a lab assessment,
Yeah.
and we may touch on that. The majority of clinicians listening won't have access to a lab, and how this may translate to the day-to-day clinician. But what does the lab assessment mean to you, and what does it look like?
Yeah, like where I'm incredibly fortunate, and the team's incredibly fortunate to work at Aspetar, and we have access to a world-leading facility and state-of-the-art movement analysis lab. And the lab is known as the Rehab Assessment and Movement Analysis Lab, RAML. And this lab is read by a guest who you've had on the podcast, Rula Kotsafaki, and her exceptional team. And it plays a central role in the rehab and return to sport decision-making process for our ACL athletes. And for every athlete undergoing ACL rehab, we conduct a lab assessment every 6 weeks, and that's mandatory. And this regular testing cycle creates a structured, objective timeline to monitor the progress and guide your clinical decisions. And there's nothing more valuable for the physiotherapists and the athletes than that mandated 6 week test. It keeps everyone accountable. It clearly shows whether you're making money and your athlete's trending in the right direction, or they're plateauing and regressing, and it sparks a lot of conversations. So if your athlete hasn't made any money on their quads in a 6 week gap, you sort of reflect. You chat to your strength power coach and you go, hey, what are we doing? You chat to the athlete, okay, why you haven't moved in the right direction in this 6 week block, and it makes you dive deeper and forces you to ask the question of why, which is really, really good. So it's what makes the lab really, really powerful as well is that it's all the testing is run by the lab team, the physio and the strength coach. They're removed from the test, so it's unbiased, and the non-treating team are removed from it. So it makes it really, really objective, and it really complements our clinical findings.
Okay, so what does it actually look like?
Yeah, so the lab is broken down into some key components. So firstly, it starts with a clinical summary. They look at pain, so how much pain they have out of 10, where the location of the pain is, and what are the aggravating activities. The lab team look at range of motion. They measure flexion, extension, swelling using the stroke test, and then also the psychology of the patient. So the patient reported outcomes through the IKDC and the TSK. And the clinical summary, it provides a well-rounded overview of the athlete's current status, and that's the clinical status and also how they are psychologically. The next key component that the lab look at is a motor control assessment. They look at a double single leg squat and also a single leg step down. And these key tests performed are looking at the kinetics, which are forces around the joint, and kinematics, which is angles, and then also looks at the movement quality and also compensatory strategies. So are they offsetting one side to the other side? The next key component which is looked at is strength testing. So this is done with an isokinetic test of the quads and hamstrings. Initially, it starts with an isometric strength test, and then progresses to concentric and eccentric strength performance, and also limb symmetry is calculated here as well. And the other strength tests are done around the hip, which using a handheld dynamometer, looking at hip abduction, hip adduction, and hip external rotation. And then finally, the final strength measure is isometric ankle plantar flexion test, evaluating calf strength. And then the fourth key component looked at in the lab is explosiveness, looking at double and single leg counter movement jump. And the key performance metrics that are looked at are jump height, eccentric and concentric impulses, and peak landing forces, and obviously differences between the sides. And then single leg hop for distance, where there's distances measured and differences between the sides as well. And progressing down to reactive strength, another key component which is measured through drop jump and single leg drop jump testing. And the key metrics measured there are jump height, contact time, and from that reactive strength index is calculated. And then other performance metrics such as impulses and peak landing forces are measured. And then finally, getting towards the pointy end of rehabilitation and testing, a biomechanical assessment is done. And this is where a 3D motion capture analysis is performed, and where both kinematics, joint angles, and kinetics forces around the joints are analyzed. And what's analyzed is the jump test, both the explosive and the reactive strength tests, as I've just mentioned, but also a running biomechanics assessment is done on the treadmill, which has inbuilt force plates, and also a change of direction assessment is done as well. So basically, we use the lab at testing at key checkpoints to guide the periodization and ensure that our rehab program is data-driven and progressive and specific to the athlete's needs. And the lab data, it complements clinical assessments by providing a deeper layer of objective information that allows us to confidently plan the next phase of rehab. So, and it's a really, really good resource to have.
Yeah, I chatted with Rula about this when she came on most recently, of accepting that y'all have a legit setup and that the vast majority of people don't have that. And she gave the options of there's still so much that can and should be done in the typical orthopedic setting that a lot of clinicians find themselves in with limited resources, by purchasing, a lot of these more affordable inline pull dynamometers, or having a handheld dynamometer, using the My Jump app, still prioritizing those kind of early kind of joint assessments of range of motion, swelling, the psychological outcome measures. Anyone can utilize those. So there's a lot of things, even within the exam that you mentioned, that can still be performed either identically or in a modified, more affordable manner, that is still having those every 4 to 6 week checkpoints that may not be as elaborate, or have some detailed things that you all have access to, but a lot of those things are still in place and should be in place for the clinician that doesn't have the resources you all have at Aspetar.
Yeah, exactly right, Chris. And I think being objective and data driven in your approach to rehab is really, really important. And just licking your finger and sticking it in the air and going, oh yeah, I think they're ready to run, in my opinion, is not good enough. Like, the athlete needs to earn the right to run. They need to earn the right to then go into training. Then they need to earn the right to play. And having a battery of testing is really important. And and everyone has access to, like, if you don't have access to the gold standard that we have at Aspetar, the 3D Biomech Lab, you should, as you just mentioned there, you got the My Jump app, you got force plates, you got a jump mat, which is a more affordable option, and then you got isometric testing. So that you need to have a battery of tests, and you need to look up and what's best for you and your athlete based on the resources that you have available to yourself. You can't just push the boat out and hope for the best. In my opinion.
Let's go into how some of uh, these priorities and goals change and evolve over the course of rehab and throughout these different kind of phases of rehab.
Yeah, and obviously there are different checkpoints, and the athlete is tested every 6 weeks, but it depends on how the athlete is progressing first and foremost. So I'll give a bit of a rough guide of a best case scenario of an athlete progressing through the different phases that we have at Aspetar and the different tests that they do and what the goals are for those phases as well. But the the treating physio needs to communicate to the lab, and we do, before they go for a test and go, hey, you know what, they're actually not ready to do the running assessment, or you know what, they're actually not ready to do the jump assessment. So this is just a really rough guide, and don't worry about the time frame as much, but more what the phases are and what we test at the end of each phase. So the foundation phase is basically the first 6 weeks, and let's assume, like as I explained before, our main focus during that phase, we want to get our swelling down, we want to get the knee straight, we want to get them bending well, and we want to initiate some basic strength and motor control patterns. And what the lab tests at the 6 week mark, if they're clear to do so, obviously everyone does a mandatory clinical assessment where they look at the joint effusion and the grading, as I explained before. They look at the range of motion of their knee, but pending if there's any precautions around their knee, they'll be able to do a strength assessment, which is just purely isometric for quads, hammies, and around the hip, and then some basic baseline motor control assessment, the double and the single leg squat. So that's the first test if there's no precautions or restrictions from the surgeon and the treating physio. The next phase is the reload phase, and that's the 12-week test. And the main focus of that 6 to 12 week test, or the 6 to 12 week mark of the rehab, you basically want to start to get the athlete strong. You want to restore some movement patterns and good quality movement patterns. And in the background, some really low level explosiveness work is starting to be introduced, and reactive strength work and running mechanics. And at Aspetar, during that phase, in the running mechanics, they would have started doing some running in the pool, in our treadmills in the pool. So, and at that 12-week mark, if the athlete's trending well and doing really well, the testing includes what was included in the first 6 weeks. So they got the clinical, and then they then move into an isokinetic test of their quads and hamstrings of the concentrics, at 60 degrees a second. And we look at performance metrics, and we look at symmetry. We look at their calf strength, and we also look at their hip strength around, with the handheld dynamometer. And one of our KPIs, we want to get the athletes starting to run. We want their quad strength within 30% or above 200% of their body weight before they are starting to run over ground. So that is a bit of a KPI at that 12 to 15 week mark when they do start to run over ground. So we do that test at the 12-week mark, and we can see if they're trending in the right direction to earn the right to start that over ground running.
Can I pause you real
Yeah.
quick?
Yeah. Jump in,
Did you
mate.
say over 200% of their body weight that they should be
Yeah.
taking out?
For quads, yeah. Before that 15-week mark of running over ground, full body weight. Yep. So, or 30% of, there's a difference between their sides of 30%. So they're two KPIs. That's the KPI for their quad strength, as well as other KPIs that they need to achieve before they start, full body weight, 100% body weight running.
Okay, so if they weigh like 100 kilos, they should be kicking out 200 kilos. You said
Yep.
200% of their body weight?
Yep. So it's their peak torque is measured. It's measured in newtons. So yeah, they
Got it.
are kicking out whatever the calculation is there. Yeah, but it's measured. It's measured in percent body weight. That's the metric that we go off.
Got it. Okay,
Yeah.
cool.
Yeah. Again, that's available. Like our return to running is available in our ACL protocol on the Aspetar website. So if anyone wants to see what we're doing for our KPIs for running, for return to sport specific, for return to play, that all our metrics are all available to the public in that protocol, which has been put together, which is a really, really good resource. So just to jump back into that 12-week mark, we're looking clinical. We want to make sure that their knee's pretty quiet. As I said, we've got some KPIs around some strength markers. We also want to look at what their motor control capacity is like, and does their knee have good capacity in a single leg squat? And what I mean by that is, are they able to squat down past 90 degrees? And that's a pretty important KPI for us. And we, with that squat, that single leg squat down to 90 degrees, we usually go, right, their knee's pretty happy here. And with a couple of other KPIs, we then refer them onto our strength power team. So that 12-week test is a pretty significant test for us to determine whether the athlete is ready to move on to the strength power team here at Aspetar. And that squatting down to 90 degrees is one of those KPIs. So then they're in the accumulation phase. So they're going from that 13 to 18 week mark, and they're progressing their running during that phase. They're progressing their strength development with the strength power team. They're building on that explosiveness and reactive strength. And they're starting to introduce some foundational change of direction mechanics as well. And they complete the test at the 18-week benchmark. And then what we then see, what we want to determine is what their strength is like and what their performance and what the symmetry is like. But we're also in that phase there at the 18-week test. We're also looking at what their explosiveness is like. So what their jump is like, what their single leg counter movement jump is like, what their reactive strength performance is like through the drop jump and single leg drop jump, and what the key metrics there and symmetry are there as well. And again, our KPI is to get our athletes to the pitch after that test. And what we're basically looking for there is, we want all our strength and our explosiveness and our reactive strength markers to have 80% LSI or a 20% difference between sides. So again, that's a key KPI and a key time point for our athletes. But not everyone gets there, and that's fine for different reasons. They might have a meniscal repair, or they might be carrying a little bit of swelling, or whatever the reason may be. But that's our gold standard, and that's our KPI at that 18-week mark, is for them to move out onto the pitch to commence sport specific. Then once they're doing sport specific during that 19 to 24-week mark, they're progressing with our on-field sport specific team, and they're doing some drills with them. And then halfway through sport specific, they're retested. And what they're also doing during that 18 to 24 mark, they're with the strength power team, trying to sort of finalize those strength power qualities. And we're sharpening up their running mechanics and change of direction efficiency. And then at that time point of that sport specific test, they're then doing everything in that 18-week test. So clinical, strength, power, reactive strength testing. But at this time point, they're doing the 3D motion capture biomechanical assessment. So they're getting all all their jumps analyzed with the motion capture. Um, their treadmill running is getting assessed, and their change of direction is also getting assessed. And what we're getting, we're doing a deeper dive, and we're getting an understanding of how the athlete is achieving their jumps and their strength, and we're looking at the quality of their movement, and that's what the biomechanical assessment gives us. And that final phase of our rehabilitation is really, really sharpening the knife and ensuring that all those biomechanical um, deficiencies and those strength power deficiencies are finalized before discharge. And as I said, on our protocol available on our website, it shows all our criteria to discharge an athlete for them to return to train with their club before they go back. So that this multi-layered integrative approach ensures that our athletes aren't just returning to sport based on time or feel, as I discussed before, but it's objective data, and we're highly confident that they're going to be successful when they do return to train, given that when they do return to train back with their club, that it's a progressive approach.
Yeah, I was trying to pull back up the y'all's um return to sport kind of CPG or guideline.
Yep.
Correct me if I'm wrong, but pretty much everything y'all are wanting to be 100% symmetry. Is that correct?
Yeah, we aim for 100%. We want them to be in really, really good shape when they return to play. But our cutoffs are 90% lower limb symmetry before they're discharged.
Okay, got it. Yeah, I was about to say 100 is I would be very surprised if every single athlete is able to get there in a certain
Yeah,
period.
correct,
Yeah.
correct, correct. And all it is the criteria is there as an insurance policy. That's all it is. It's just decreasing the risk of them reoccurring, and we don't want them to reoccur. Um, so that's all it is. It's an insurance policy.
All right, let's go into this final section, Luke. We're over an
Yep.
hour in, and you've
Yeah.
gone through a ton. So this has been great. But I'm very curious how, with your own clinical experience and your time, pre-Aspetar and the past 2 years you've been at Aspetar, how is your approach for managing these knee and more specifically ACL rehabs? How has it evolved?
Yeah, like throughout the course of my career, a lot has changed in how I examine a patient, assess an injury, and the approach and the overall testing process through a lot of technology as well, specifically with the testing process. But at the same time, some core foundations have remained pretty consistent. And but what's changed is that I've become more refined and deliberate with experience. And in my formative years, going back 15 plus years when I first became a physio, I was really fortunate to work alongside some really experienced clinicians, um, including physiotherapists, orthopedic surgeons, and sports physicians at a multidisciplinary clinic. So the way I was taught to assess a knee back then largely shaped how I assess one now. And that's having clear structure and flow to the clinical assessment. And that hasn't really changed. But as I said, the level of precision and depth and interpretation and clinical reasoning has changed. Um, and obviously that's changed as I've become more experienced. And that refinement has taken a big step forward whilst I've been working at Aspetar. And number one, I'm surrounded by a highly specialized team who are very, very experienced. And we see a high volume of knee injuries. And when you work in an environment when you're constantly exposed to elite level ACL and knee rehab, and you're collaborating daily with some world class physios, strength and conditioning staff, and knee surgeons, you naturally develop a more sophisticated lens for assessment and managing of knee. of knees. So one of the biggest areas of growth and assessment for me has been in the motor control assessment, and that's particular in lower limb rehab and ACLs. And this part of my assessment process has been shaped significantly by the work of Enda King, and also some experienced team members in the knee group at Aspetar, Brendan Butler, Sean Jankelson, and Konstantinos Deftados. That's a hard one to pronounce, but yeah, those guys led by Endo has really shaped that motor control part of the assessment, and the way we analyze and interpret movement quality, how the foot, how the knee, how the hip, how the trunk interact during functional tasks has become a core part of both our assessment, which I discussed before, and I only touched on it, and our treatment philosophy here at Aspetar. And it's something I've really come to value and integrate into my day-to-day clinical reasoning. And the evolution of the testing process, obviously that's evolved through my career, and I discussed the importance of being objective in your rehabilitation and athletes earning the right to progress through the different milestones of rehab. And obviously the testing process has evolved through access to technology, and that originally started at the Australian Institute of Sport when I worked at Australian Rugby Union, and then having access when I worked at in the AFL. We had a partnership with a local university and gathering isokinetic data and force plate data through them. And then we started to get some equipment at GWS. And then also I leaned heavily on an external provider, Tim McGrath, who works in the States, and doing some advanced ACL return to play testing in Australia. So since joining Aspetar, that testing process has gone to another level, and the biomechanics and performance testing conducted through the lab is truly world class, and Ruler has done a really, really good job in that space. And it's structured, it's periodic, it's unbiased, and it integrates into your clinical strength and movements, and it's really cohesive and creates a cohesive picture in your management of athletes. And we're not just asking athletes how they're going, we're quantifying it, and we're tracking it over time, and we're really using data to inform our decision making and progress our rehab when we're returning to sport.
All right, Luke, any other final thoughts before we wrap it up?
Yeah, just to sum it up, I guess my clinical assessment has become a bit sharper. I've got more of the motor control focus into my assessment, and that, as I said, that biomechanical objective data driven approach is really rounding off how we're doing things. And my testing process and tools to multi-system and performance model has really, really progressed. And this evolution has been shaped by many people I've worked with. I've mentioned a couple, but I haven't mentioned a lot of them, and I'm truly grateful for a lot of the places that I've worked at, and it's really shaped who I am today as a clinician. And yeah, it's been a good process.
Well, that's awesome. This was very thorough. I will link in the Aspetar ACL kind of guideline, the recent knee PDF on the website. If there's anything else you want me to include that would be beneficial, I can put that in the show notes. This was great, Luke. We'll call it there.
Yeah, thanks a lot for having me, mate. I really appreciate the chat.